I'm Dani Gasparini, and welcome to this segment of Penn Voice. I'm joined today by Dr. Dirk Baumann, who is the medical director with the Mills-Peninsula Medical Center Heart, Brain, and Vascular Institute. I hope I got that all correct. Thank you, Dr. Baumann, for joining us. We're going to talk about a specific condition today, aneurysms. But please tell our audience why today we want to be talking about aneurysms.
So the risks that relate to aneurysms, particularly of the aorta, the main blood vessel in the body, is the risk of rupture. So if we can identify someone as having an aneurysm before they're having any symptoms from it, we can often repair that aneurysm electively with relatively non-invasive surgery now and allow them to continue with a normal life expectancy. Whereas if the patient is not diagnosed, those aneurysms can burst or rupture, and those are much harder to repair and have about a 90% mortality rate. So if we can identify the aneurysms first, we can fix them much more easily and allow people to have a normal life expectancy.
So with programs like this, we just are hoping that we're going to get some information out to our viewers that happen to be watching the show and say, this could be you. Is an aneurysm something that can happen to anyone, or do you look at certain populations? Who's at risk?
Yeah, so aneurysms are an enlargement of the aorta and other blood vessels throughout the body. The main risks associated with aneurysms are older age. That is, as we age, our blood vessels tend to dilate or enlarge. Males are much more commonly affected by aneurysms. Around 4 to 8% of males over 50 develop aortic aneurysms. Females less so, around 1.5%. Caucasians more commonly have aneurysms than other races. And then aneurysms are also associated with other diseases, so high blood pressure, atherosclerosis or hardening of the arteries. Also predispose people to develop aneurysms. And the final group of patients is those with a family history. That is, patients who've had a parent or a sibling that has an aneurysm are at much higher risk for aneurysm development.
So, which I guess the good news is that it is related to other disease states, and it does have some gender age factors, so that we can begin to get into a screening program, which leads to your prevention or your repair issue, which you brought in the beginning, has the greatest chances for life and recovery, right? So tell us a little bit about that. So I might be someone who is then diagnosed with either some high blood pressure or I've got some high cholesterol. Is that something I need to talk to my doctor about, or are they going to say to me, here are some of the risk factors outside of what we're treating you for?
Yeah, so the main indications now for further studies or evaluation for aortic aneurysm are males over 65 who've ever smoked. So I didn't mention earlier, but smoking is a big risk factor. It not only creates the development of aneurysms, but also speeds the rate at which they grow. So currently Medicare covers a screening ultrasound, which is the way we typically screen patients for aneurysms at age 65 on enrollment in Medicare. Males who have ever smoked, males who've had a family history of aortic aneurysms, and females who have a history of aortic aneurysms.
Would it be fair to say, if we had a viewer that has experienced any of those risk factors in their current life or historically in their family, for them to bring that subject up to their cardiologist or even to their general practitioner physician and say, I was watching this program and I heard something about aneurysms. Is it fair for that person to say, hey, would I be a candidate, or would I need screening?
Yes, absolutely. I think most of these are diagnosed now by the primary care, the family physicians. I think it's reasonable to bring up. The family physician can assess their risks and decide whether screening is appropriate or not. The screening test is an ultrasound test. It doesn't require x-rays or any risk. And so it's something that's very simple for patients to tolerate.
So I don't think I would have ever thought about aneurysms today. And you brought some great some great visuals that you can sort of tell us a little bit about the process and what happens and what they are. You said a little bit in the beginning, it's the ballooning of an artery, so it's the opening of an artery, almost like a balloon effect, as you said, and then it bursts. Do I know that one is developing or that one is starting to enlarge? Can I feel any of those symptoms?
Yeah, so no, unfortunately, people usually don't have any symptoms from aneurysms, and so that's the importance of having some other sort of testing. Now, about half of large aneurysms can be felt on a physical examination by a physician, but most of the time it really requires additional testing, like an ultrasound or a CT scan. We often pick up aneurysms incidentally now on ultrasounds while we're doing an ultrasound for something else, or on a CT scan while we're trying to evaluate something else.
So show us a little bit what happens when someone is having an aneurysm, or what happens with the blood vessel, the aortic blood vessel.
Yeah, so this is a model of the aorta. This is about the level of the belly button here. The aorta comes down and has multiple branches. These are the artery branches to the kidneys. The most common place for aneurysms to occur is below the kidney arteries in the belly. The aorta, the main blood vessel, branches into the arteries called the iliac arteries going to the right and to the left leg. These arteries can also be aneurysmal. But this aortic aneurysm is the most common place for people to develop these type of aneurysms, and this segment can grow and enlarge to the point where it becomes very weak and then can rupture or burst.
I'm glad that you showed us this depiction, because then it makes screening a little bit more tricky, because an aneurysm can show up anywhere. I mean, you did say that it's concentrated sort of below kidney, but really, wherever there's an artery, there's an opportunity for an aneurysm to form. So how do you then do screening? Is it a full body scan to do baseline?
So you're absolutely correct. Aneurysms can occur in any arteries anywhere in the body. The most common area by far is the aorta in the abdomen. When people do have aneurysms of the aorta, however, they can also develop aneurysms other places more commonly. So those include the iliac arteries, as I described, the femoral arteries, which are the arteries in the groin, or the popliteal arteries, which are the arteries behind the knee. So when we find someone with an aneurysm, even if it's a relatively small aneurysm, we will screen those other areas to make sure that they don't have aneurysms in those locations as well.
So once you detect, what's then the course of action?
Yeah, so there's no medical treatment other than stopping smoking cessation, to help an aneurysm grow more slowly. So the good side of that is there's really no restrictions in following those patients. And the indications for surgery are really when the risk of fixing the aneurysm is lower than the risk of it bursting. That is, as the aneurysms grow, we know that when aneurysms get to be around 5.5 centimeters, a little over 2 inches, they are at much higher risk of rupturing. And the larger they grow, the risk increases exponentially.
So once you see someone, then you're gonna follow them to ensure that the growth is very slow, if negligible.
Correct. So if an aneurysm is smaller than 5.5 centimeters, we follow with ultrasounds usually every 6 months to monitor its growth. Now, unfortunately, aneurysms don't just gradually grow. They grow in bits and spurts, so we need to continue to follow those patients lifelong.
So if one does burst, then what is your course of action? What happens to the patient? And what do you do?
We can often try to fix those. Again, it depends a little bit on how severely the aneurysm ruptures. Sometimes they just rupture into the back and the blood is relatively contained, and then we can fix those. Usually we call it endovascularly within the blood vessels themselves. And for that we use a stent that is similar to this, which is compressed within a sleeve. We pass it in through the arteries in the groin and position it above where the aneurysm starts so that it can seal in this segment above the aneurysm, and it seals below the aneurysm. So now all the blood is flowing through the inside of the graft but the aneurysm is no longer pressurized, and gradually over time it shrinks.
Right. Well, we are out of time, but I want to say thank you so much for bringing this public health information out to all of us, because it's something that I don't think I would have thought about. And I think now people have the tools and the information to go ask their general practice physicians to say, am I a candidate? Is this something that we should be talking about?
Thank you for having me.
Well,
Appreciate
and thank
it.
you for bringing this information to us. And we'll see all of you next time on Penn Voice.